Hey, good afternoon, Kiani. Can you hear me?
Yes. Good afternoon. Rukia, I need you host, and then you can actually change the setting for share screen.
Perfect, thank you.
Thank you, Kiani. Thank you, Rukia. Can you hear me?
Yes.
Aloha, this is General Hart. Can you folks hear me okay? Over.
Hey, good afternoon, sir. This is Thomas. Yep, Lima Charlie.
Okay, thank you.
Recording in progress.
Okay, good afternoon, everybody. This is Thomas Lee, co-chair of HiPAM, joined by Dr. Victoria Fan and our distinguished speaker today, Major General Kanehara. Sir, before we get started, I'd just like to introduce you to the rest of our team and attendees to our monthly HiPAM community work group. So I'll try to be as brief as possible, but that's going to be pretty hard with your distinguished record, sir. So in 1987, I'll kind of skip some of the Army-centric stuff, sir, but I wanted to touch upon mainly especially your role with the state. But General Hara, commissioned as a second lieutenant of infantry through OCS, Hawaii Army National Guard, served in numerous positions of increased authority. Ultimately, as commanding general of the Hawaii Army National Guard. On the federal side, in 2005, General Hara deployed 3 times, commanding 1st, 2nd Battalion, 299th Infantry to Baghdad in support of OIF Operation Iraqi Freedom, and deployed again 2008 as a deputy commander of 29th Infantry Brigade Combat Team, and then finally in 2012 as the commander of the Operations Coordination Cell, Regional Command South in Afghanistan, Kandahar, Afghanistan. Specifically to Hawaii, he has served on several state missions in support of local authorities. Most notable were his duties as Assistant Ops Officer with the 2nd Battalion, 299th Infantry following Hurricane Iniki, September 11, 1992, as Task Force COA Commander, comprised of Hawaii Army soldiers and Air National Guards airmen, conducted National Guard civil support operations following an earthquake that struck the island of Hawaii on October 15, 2006, and then as the dual status commander of Joint Task Force 50 in support of the Kilauea volcanic eruption and hurricane land responses in 2018. And then from October 2015 to 2019 December, he served as the Deputy Adjutant General of our great state of Hawaii. And currently he serves as the Adjutant General for our state of Hawaii, leading us through the pandemic response in collaboration with the rest of our state leaders. His military education, United States Army War College, CGSC, and some other staff schools. He holds a Master's of Strategic Studies from the United States Army War College and a BA in Human Services from HPU. Gonna just rattle off some of your awards and decorations, sir. Most notably the Combat Infantry Badge, Army Aviator Badge, Legion of Merit, Bronze Star Medal with Oak Leaf Cluster, and Meritorious Service Medal with 3 Oak Leaf Clusters. He is also married to the former Myung-Young Park, has 5 children, Kristen, Julian, Nicole, Justin, and Alicia. Sir, thank you for taking the time to speak with us today. The net is all yours.
Okay, thanks. Let me pull up my presentation. While I'm doing that, I'm going to, a lot of people say, wow, you had a distinguished career. And I tell them, no, but what happened was I have extremely bad luck. So every time I'm in command, there's some emergency or some deployment that's going on. So it's not about my capabilities, it's because I have bad luck. So rest assured, when I retire, Hawaii will probably be over all these different disasters and stuff. It's all my fault. Also, before I get started, so first I want to thank HiPAM for what you folks did. Right? Most of it was on voluntary status, and I can assure you, I personally used the model for making policy recommendations to the governor and the mayors, and then more importantly, internally, when I worked with HiEMA and Department of Health, using it to determine priorities and then how to allocate resources. So again, thank you for everything you did. And then Dr. Pam, I owe you, Dr. Fan, I owe you some money, and I'll link up. My ASO just got back from California, so we'll hook up a virtual meeting, or at least get you guys introduced via email. I just wanted to talk about, this is a briefing I created back in April of 2020, and I've been using it and updating it until today. So I'll go back in time and talk about the mission and the guiding principles that we've been using since the beginning. And then how I visualized and we created this state response framework, which for military folks like Dr. Lee, you understand, we do strategic planning and we have lines of effort to get us to the ends. And then the COVID metrics is showing how Hawaii was successful in being able to deal with the different surges throughout time. Real quickly over the vaccination status, and then wanted to show you guys a slide for the what's next. And that's something I just built yesterday. So I noticed there's a whole bunch of mistakes on the original briefing package that I sent up. So I owe you folks this more updated version. So, so in March of 2020, Governor Ige, Thomas talked about the different roles I have, right? So as the Adjutant General, I'm the commander of the Hawaii National Guard. I am the director of the Hawaii Emergency Management Agency. And I'm also the director of the Office of Homeland Security. So I'm Governor Ige's Homeland Security advisor. And because those are three really, really easy jobs, Governor Ige said, hey, you don't have enough on your plate, so I'm going to make you the overall incident commander for the COVID-19 response. So the pictures from that first press conference, I believe it was on 16 March. And I told the team, the planner, that said, our mission is to enable a safe, secure, and prosperous Hawaii. And I told them enable because it's not only us doing it, it's everybody. It's an all of nation, all of community approach. And to be prosperous, if we're not safe and secure, Hawaii will never be prosperous. So we started with that. And in the guiding principles, the most important thing was to save lives and prevent human suffering. And everything that we did, I took from the lens of, are we saving lives or are we trying to prevent human suffering? And that's how we put the priorities and the resources to bear. Then it was HTA, Mr. DeFries, that talked to me. I heard him say, like, hey, if you malama me, I malama you. And then I thought, man, that really makes a lot of sense. So with that, my takeaway was everyone has an individual responsibility. And I truly believe the reason Hawaii has been successful to bring the curve down after we had a surge is because the people of Hawaii sacrificed. They realized that I have a responsibility, right? That kuleana, to be able to malama, to take care of not themselves, but by taking care of myself, I'm also taking care of others. And that's for the collective well-being. And then the last point is we mitigated risk through layered safety measures. And the example I like to use for that is the Safe Travels Hawaii program. So we took that and said, okay, what is one layer? I said, okay, we're going to require that travelers test. We're also going to require that they can only test, they need to take the nucleic acid amplification test. And it must be from a trusted testing partner. And then we created the digital platform where you answer certain fields. There's a questionnaire, there was a health survey. So they got to fill out the questionnaire in the digital platform. And then they fly over, then they get screened. And then if you don't meet the requirements of safe travels, you're placed into travel quarantine. And then enforcement takes over after that. So that multiple layers mitigated risks to an acceptable level Hawaii. And I believe it did work in reducing the virus from coming into Hawaii and spreading. So this slide, I used to hear people, like, especially the public health folks, right? And the medical side, a lot of them was, hey, we need stricter policies to save lives and prevent human suffering. So we need a lockdown or, whatever it was. And then on the other end of the spectrum, it was, no, we need to relax the policies. We need to open the economy because there is human suffering tied to economic tragedy. And then some people are actually, committing suicide, or you got abuse, household abuse, all related to the economy, and the people not being able to put a roof over their heads or feed their families, having food on the table. So the challenge for the policymakers is where, if you look at that white arrow, where are you, right? It's pointing to the right because right now Hawaii, we're trending towards, less cases, less hospitalization, less deaths. But that shifts depending on the conditions. So where the biggest challenge is that natural tension is, where do the policymakers, where are they? What decisions do they make? What constraints do they put on the public to try to reduce the disease? And we weren't always perfect, and sometimes we may have been too strict or too relaxed, but I can tell you that was a huge challenge for the governor and the mayors. So this is the response framework we look. So typical way we try to frame everything. What are the ends? Where are we trying to get? What is success? And then what are the ways and means to get there? So I looked at it from what I talked about, that policy decision making. So what are the policies? And then using the pandemic control actions, right? How do we prevent the disease from coming into Hawaii? How do we prevent it from spreading? To be able to prevent it, we need to be able to detect it. And then once we detect it, we need to contain it. And then once we have people that are sick, treating them or other measures required. And we've used this since March of 2020, and it still works here in February of 2022. And then you can look along those, the lines of the response framework, you know, as if you go to the policies way back when it was bad and we didn't know what we didn't know, right? We did the stay-at-home order. What's worked really well for Hawaii is the safe practices and other non-pharmaceutical measures. You know, on the prevention side, we spent over $100 million buying the personal protective equipment and industrial hygiene products. And then now we got, you know, the vaccinations are a great way. If, you know, not only fully vaccinated, but now being up to date and getting your booster if required. And then the testing strategy. And then initially, we had pretty robust isolation quarantine units to help us to contain the virus from spreading. And then now, you know, the emergency treatments like the monoclonal treatment and other stuff that's really helping to save lives. So this has worked then, like I said, and it's working now. And then the ends is, how do we transition to a new acceptable norm? And I say acceptable norm, and the example I give people is, if you remember 9/11 during the terrorist attacks, the new norm was National Guardsmen armed, right, with rifles and pistols and ammunition at our airports. That was the new norm, and everybody had to get screened 100%. That wasn't the norm previously. So now you got all these National Guard folks in there doing security. But eventually we transitioned, they created a new department, Homeland Security, and then TSA in the airports, to where now that is the new accepted norm. Everyone knows if you travel now, you got to show up there earlier than you used to, because you got to go through all that security being conducted by TSA. So what is the new accepted norm? And to be honest, I don't know what that is yet. This one here is just really a snapshot. I tried to look at from January. You know, we had a little uptick from January of 2021, uptick in cases that we normally do during the winter. Got that under control, you know, 37 new cases. And all of these numbers, the daily cases and and the positivity rate are the 7-day average. It's not just one day. So from 189 to 37, then we had that Delta surge. So September, I think the highest average was 881 cases, 425 hospitalized. And then we brought that down, you know, 75 daily new cases in November. And then by January, we're at 4,500. And then today, the weekly average is 859 with an 8.4 positivity rate and 192 hospitalized today. The January 21 of the year 2022, I got the question mark for the positivity rate. That's because DOH was saying the system was getting overwhelmed and they weren't putting in the negative tests. So they couldn't figure out what the positivity rate was. And then real quickly, this was as of today. So 82.5% are initiated, 75.3 completed their primary series. And then 35.9% got their booster shot. And if you just look at the eligible population, that's 56.7%. So it's right now, it's like watching water boil. It's slow, but we are still in every category I've been watching. We are still trending in the right direction. Even the initiated, that bumped up as well. So here's my last slide. So what are the conditions for what's next? I just showed this to Governor Ige just before signing on to here, and he was like, "Oh man, I need that slide. Give me that." But really, what is going to happen? What's next? You know, the nationwide emergency declaration that President Biden signed, that expires. Oh shit, sorry. Sorry, it's right. It expires on March 1st, 2022. And then the HHS public health emergency that was issued in January of 2022, that expires April 16th. So are those two federal declarations going to be extended? We're not sure, and maybe not. And then Hawaii's own, right, our emergency proclamation, the amendment issued in January, that ends on 25 March 2022. The fourth bullet, that Stafford Act, direct federal assistance, that's the authority. So people get confused between the American Rescue Plan, and you hear ARPA commonly, and then they don't understand what Stafford Act and direct federal assistance is. So Stafford Act, that's when, if there's something that the state expends money on that's qualified under the emergency declaration, the state can request for reimbursement. And currently that is at 100%. So let's say I stand up testing sites. I didn't have the money that ARPA funds to pay for it. I pay $10 million. I can file to FEMA for reimbursement of that $10 million. And then direct federal assistance is a federal entity providing that support to you, whereby you do not need to pay for it currently, because it is at 100%. And then that you see that 32 USC, sometimes you'll hear people say Title 32. And 502F that's the authority that allows National Guard to be placed on a federal status, but still be under the command and control of the governor of each state and territory. So the authority and the funding under Title 32, 502F expires on 1 April, as does the Stafford Act and Direct Federal Assistance Program. And we don't know if both of those or one of those will get extended or not. And in the American Rescue Plan, there's one provision under there called the State and Local Fiscal Recovery Funds. So the state of Hawaii got money, and then the counties, all 4 counties got money. There are guidelines of what they can spend the money on, and they determine what they spend it on. It's not directive. That money expires on December 31, 2024. So everything needs to be obligated. And then we know that the invoices come in after the fact. You can continue to pay the bills that was executed up to 2024. You can pay all those bills out to 2026, which is a good thing, because even for us, for the CARES funding that expired in December of 2021, if they didn't give us that little window at the tail end, we wouldn't be able to pay out the bills after the fact. So I'm glad the federal government figured that out. And then, what are the conditions? When will the governor and the mayors feel comfortable to also end the Safe Travels Hawaii program? And then when does, CDC say, yeah, we've transitioned from a pandemic to an endemic? I believe that in the near future, the nationwide emergency declaration will expire without an extension. I believe HHS will not issue another 90-day public health emergency unless there's another spike, but we'll still be in a pandemic. And my belief is that Hawaii needs to be postured and plan for another surge, but not expect federal funding, because I don't know how the federal government, will they be willing to declare another emergency declaration and to declare another public health emergency. I'm not sure if they would, unless it's really, really bad. So that's kind of where we were, how we got to where we are, and really what's next is undetermined at this time. So
thank you for your time and your insights, sir. I know we all greatly appreciate it. Okay, so we have a pretty full house. So just gonna go over once again, how we kind of conduct our weekly, what used to be weekly, now monthly community meetings, and hopefully we were able to add in some of Monique's Hawaii specific modeling as well. Next slide, please, Rukia. So once again, as you know, to really reiterate what General Harris said, you know, where we are in the Pacific, we are unique in terms of our location and the volume of travel that we get internationally. So, you know, from the get-go, I would say from, you know, when we started to do these weekly, we incorporated Japan, Korea, and then, you know, when Delta came with India, just to look at the major countries and how they were handling COVID. So obviously Japan is experiencing their Omicron surge. They do have slightly tighter restrictions when it comes to travel entering their country than ours. So, you know, we're just seeing this trend kind of delayed from country to country and from region to region. Next slide, please. Same with South Korea. You know, for those that want to just take a step back in time, you know, South Korea and Japan were obviously, due to their geography, were one of the first to experience COVID. And then for Hawaii, we typically looked at them as, you know, a leading indicator to see how we might get hit, because the trend was it'll be Asia, then Europe, then continental United States, and then finally Hawaii. Now, because of, you know, the variants and just travel picking back up, you know, we've lost that pattern. So part of our role is to look for, in terms of, you know, the various countries where we can kind of gain some insight in how COVID or whatever variant it is at the time might impact Hawaii. But right now, Korea and Japan are obviously going through the Omicron surge. Next slide, please. India experienced their surge. They're coming down at a rate that's pretty rapid. And what we're seeing across the board is a pretty rapid decline. But, you know, it's hard to assume that that's what we're seeing in Hawaii, especially given some of the data limitations that General Hart mentioned DOH is experiencing. Next slide, please. National overview. So hopefully, knock on wood, we will continue to trend down and have, you know, a couple bumps here and there, but nothing as drastic as we experienced with Omicron. But as with Delta and the original surge, you know, it's, while we're coming down nationally, there will be pockets and cities in the Midwest and the rural areas that will still be dealing with COVID. So while we are looking fairly good on a national aspect, we still have to remember that there are possibilities, there are communities that are still experiencing COVID and Omicron relatively severely, even though we may not be as much. Next slide, please. So once again, you know, focusing first on the international, you know, travel and heavily traveled areas. Now, you know, the 4 states, Arizona, California, Texas, and we leave Nevada, we always focus on, once again, because we get a lot of travel from and to and from for our residents. So once again, it looks like Arizona and California, they are also trending downward from their Omicron surge, you know, consistent with what we're seeing nationally and within our state. Next slide, please, Rukia. Same, Nevada and Texas. Once again, you know, trends continue to mirror what we're seeing nationally. Once again, hoping that this will hold true. Next slide, please. So focusing on Hawaii specifically, you know, everybody that checks the news, you know, this is not a surprise. From early January through, you know, through now, the epi curve cases per 100,000 obviously haven't been good. You know, the caveat to the percent positivity, General Harris said again, you know, there are some gaps in the past couple of weeks due to the capacity issue of just going through the volumes of negative tests to really be able to calculate test positivity. But, you know, the data that we did have, you know, is up to 15%, the highest it's ever been for Hawaii. So once again, hopefully we will continue to trend downwards in these 2 metrics, both cases per 100,000 and our test positivity rate. Next slide. You know, vaccination progress, you know, we continue to increase, though probably at a slower pace than the initial surge to vaccines. Good to see that DOH is tracking that 3rd dose, and CDC did make some parts of the population eligible for a 4th dose. You know, will be interesting to see at a national level where the discussion leads with regards to a 4th dose and you know, the transition to a 3-dose series versus a 2-dose and a booster. You know, we're still waiting for more updates from the FDA and the CDC. Next slide, please. So for our forecast overview, this is what we have on our webpage. You know, the real data is the purple, and then you'll have our optimistic, our pessimistic, and our best fit model. You know, oftentimes people will get on us for it not being aligned exactly, but understanding that our model from day one has meant to inform, but also we inspire others to the community. It's led by individual actions, like General Hart said, to defeat the model in terms of let's try not to make the model come true through individual behavior. And so far, so good. Next slide, please. So this is just the same set of information you just saw previously, just in a numerical format. Next slide. So, obviously there continues to be just incredible advances and publications on all sorts of COVID-related research, both clinically, public health, social determinants, mental health, etc. But wanting to use this opportunity to just summarize some major operational highlights that will impact either you directly or people that through families or keiki. Myself as a new father, I'm paying a lot of attention to the possible EUA emergency use authorization approval for the Pfizer vaccine for the under 5, and then updates to the mask wearing, and then whether or not that will change for school. So just going to touch upon 4, and then hand it off to Dr. Monique Shiba for her updates. Next slide, please, Rukia. So kind of lost in a lot of the cases and other news is the fact that the FDA approved and the CDC's ACIP backed the full approval, FDA's full approval of Moderna's COVID-19 vaccine. So once again, just like Pfizer's fully approved vaccine is known as Comirnaty, there's another name, just as if things weren't confusing enough. The approved version of the Moderna vaccine is known as Spikevax. Important to note when you communicate this to your friends, your family, that there is absolutely no difference, and that they just needed to have a name for the licensed product. We're still waiting for CDC guidance on the implementation of it. But in simple terms, what we're looking at right now, what does it mean for us? Now it means that both Pfizer and Moderna are fully approved vaccines. From the communications aspect, the one of the talking points for the vaccine hesitant or the crowd that wanted to have more information was, well, there weren't any that were approved. Well, now there's 2, and we have a lot more data for both the efficacy and the safety of it. And then obviously for the military, that's another set of vaccines that can be utilized for the mandatory vaccinations. Next slide, please. So once again, a little more near and dear to my heart as a younger parent of a 10-month-old. Before this kind of hit the street, acknowledging that everybody has different risk tolerance based on their situation, which makes it really difficult for policymakers to weigh the pros and cons of policy that General Hart talked about. I had to be a lot more careful with mask wearing who I interacted with, because although I was protecting myself, I couldn't really take a chance for my daughter. So once again, this is some uplifting news. We still haven't seen any data released from Pfizer, but from what the FDA has put out, that they are expecting to make a decision for approval or denial of the emergency use authorization for the under 5 dosage. We don't know what the dosage is going to be, the regimen, but expecting at least the first 2 doses of a planned 3 dose. And then this, on the last bullet, I kind of put the dosage and the timeline for that. So more to follow for this, but some positive news. And then obviously going to have a lot of rippling effects for our keiki, and policy surrounding schools and masks and quarantine and isolation policies for schools and our keiki. So hopefully will be better news than what we've had to experience. Next slides. Let me see. Okay. So the third one I wanted to just point out, a lot have been made of masks, what type of mask, when to wear masks, when to switch them out. And, CDC published a few days ago another update And I just want to summarize what was common sense, but once again, it's always good to be backed by real lab data. So, like the N95s, the KN95s are the most effective when it comes to the effectiveness of face coverings. And then, the geek in me just wanted to say that, the way they conducted the study, it wasn't the best way, but it was probably the most practical way to get some of the data. So what they showed was there was a reduction in odds of getting COVID if you wore a face mask or an N95 indoors compared to not wearing a mask at all. Next slide, please. And then just to level the boat, make sure everybody's on track of, if you were to read this, you have no mask, which is the worst thing you can do. And then you have a cloth mask, a surgical mask, and then you have your respirator, the N95 and or KN95. And then one more slide to speak to this. Next slide, please, Rukia. To speak to, so there's some confusion. When CDC updated their mask wearing guidance late January, they used the term N95, but they have to clarify there's two types of N95, the N95s and then your surgical N95s. That on the next slide, Rukia, if you can move to it. From the 3M website, this kind of delineates and differentiates the pros and the cons and how effective against different exposures and types of exposures these types of masks are. So once again, utilizing this to educate the public, there are differences even between the surgical masks, the N95s, and the surgical N95. So hopefully this is just gonna set the record straight and make it easier to identify which mask might be the most appropriate for you and your family. Next slide, please. And then finally, we're getting more information. We're still seeing a lot, at least when I'm just reading in the lay media and social media. There's still a lot of hesitation in the female population, or the potential pregnant or the currently pregnant, to getting vaccinated. And this study looked at, while the sample size was small, it's not the first study or even the third or the fourth. It continues to confirm data about the effectiveness and the safety of the vaccines, the mRNA vaccines, on pregnant mothers. And interestingly, this had a twist to it where it compared the antibody levels or the titer levels of the vaccinated mothers and the infants of the vaccinated mothers versus the mothers who had natural immunity, which meant that they got COVID and then gave birth. And the bottom line is that the vaccinated mothers passed on significantly greater antibodies and resulted in a greater antibody persistent level in the infants than the antibody or the titer levels in the infants that were born from the infected mother. So once again, vaccines are a way to control, safely get an immune response versus taking your chances by getting COVID naturally, and you may or may not have a severe reaction to that at a population level. So once again, just more information as you continue to discuss and you have people close to you or friends who are hesitating, especially for really good reasons. They may not be as educated with regards to knowing the safety when it comes to vaccinations for pregnant females. And once again, this is meant to educate and to just share the information that's coming out from peer-reviewed aspects. I'll pause for any questions before we move on to Dr. Shiva's slides. Okay, Monique, all yours.
All right, sorry. Okay, I'll go quickly because it's been already 45 minutes in that presentation. So just a quick update on the modeling. So as we are training down, it gives us an opportunity to work on the model actually and reflect on what happened. So again, as everybody know, we're in a situation where both daily cases and hospitalization are going down. Hospitalization, I'll show a little bit something. So it's been plateauing and it's not clear why. We're also, so we've done some work and analysis on heterogeneity in the island chain and how different granularity are needed and different mitigation might be needed on different islands. And we are now trying to use also what we have learned here in order to look for other islands that include American Samoa, Guam, Micronesia, and Tonga Island, that through a natural disaster, they had to lift some of their very severe restrictions. So for those islands now, the question is, how do you reopen? And we're looking into that. So here, the next slide. So what is happening right now is that there is a huge variability in the daily cases, and this is due to the fact that as we know, there've been some of a lag in reporting the positive cases. There've been also, now we have people can test at home, so that might not be reported in the daily cases. So it is difficult to base the model on those numbers. So I'm going to go and show a little bit. So we've been reflecting on the modeling and just showing some of the main updates. This is for the Omicron surge. So as we predicted and forecasted, I mean, the forecast about a month before the peak, we had the date. They were quite accurately estimated for both Honolulu and the neighbor islands. The daily cases by the model are higher than the one that were provided by the DOH, but we do assume that they represent a little closer the actual situation, and this is due to the testing. At some point we were reaching capacity, and then now we have at-home testing that are not necessarily detected and go into the count, so that seems reasonable. For the neighbor island as well, the peaks were actually reported quite accurately. The numbers, we were above, and in terms of the hospitalization as well, which was pretty good news. It's been very difficult to predict the hospitalization. So here, I'm just showing a little bit of an update on, this is the Honolulu forecasting. And so we can see we're just adding the data. At this stage, we don't have a need to actually update the model. It is following quite well what has been happening. And this is for the hospitalization. So we can see that they are decreasing and that they are in the lower part of our cone of uncertainty. So this is comparing Delta to Omicron. So you can see that indeed on the top left, the Omicron generated much more daily cases. However, in terms of hospitalization, in Honolulu, in Honolulu County, we were under the hospitalization created by the Delta, which is not the case on the outer island, on the neighbor island. So if you look at Hawaii County, for instance, so that's the daily count. So the dots are the actual numbers, and then the orange line is the 7-day averages. You can see that our model is above, but then this has been done in order to fit the actual hospitalization. What is surprising is that we have a peak, a real surge, and then decrease for the daily cases, but the hospitalization plateaued. And that's sort of a new phenomenon that happened with Omicron, where the hospitalization do not necessarily follow the trend of the daily cases, and it's unclear why. So here you can see hospitalization for Hawaii County was under with the Omicron as well, as it was for Honolulu County. So let us have a lens on Maui. Again, Maui, we can see it follows the blue curve with a lag in terms of the numbers, and those are the hospitalizations. So again, you can see there is a very fair trend at the plateauing, which is surprising given that the daily numbers have been really going up and down. Here are the hospitalizations. So Maui is the one county where hospitalization with the Omicron went beyond the hospitalization that we have for the Delta, and we're looking into that. And this is Kauai. So Kauai, we had to review a little bit the introduction of the Omicron, and now we are assuming that Omicron was introduced a little better than it was initially anticipated. And then we can see that the model does really well. Those are the hospitalization on Kauai, and they're not yet completely in a downtrend. So it is still to be watched. So what we're doing right now, because there is a little bit of a breather in terms of the urgency of the model, we're actually working really hard to upgrade the model to add different feature, like General Ara had that great highlight of the fact that this is much more than daily cases. There is much more complexity in a pandemic than just looking at the cases and the hospitalization. So we're looking at how to introduce into the model like substance abuse or mental, mental impact on the people as well. So we're working on modifying some of the model that we have. We're also looking right now at the excess death, and we're putting that together. A report should come out soon. And so we are really trying to understand a lot of the data that we were not able to analyze as we were into the emergency of the pandemic. So this is where we are.
Thank you, Dr. Shiba. Any questions for Dr. Shiba? Oh, Jarnahara, go ahead.
Hi, Dr. Shiba. My question is, do you believe, so, in the media, there's a lot of talk about Omicron not being as dangerous as Delta or previous variants. So because of people are thinking it's not as dangerous, two things I'm thinking is, when they get sick, they're either not testing, and then the other challenge is some get the home test, but are not reporting that they're infected. So it's not captured in our reports. And then also because they think it's not as dangerous, a lot of people are staying home longer until the last minute when they're like so sick, then yeah, they absolutely need to go to the hospital. And is that affecting the lag from, previously someone got infected, 5 to 7 days later, you see kind of a, proportional trend for hospitalization. But now, because people think it's not as dangerous, that kind of skews the hospitalization. I don't know if that has any impact.
It is, and it makes the all the parameters to be estimated in the model extremely difficult. And as I've been saying, it's an exponential phenomenon, so little variation might have a big impact. So it is hard to say how the fact that people can test at home is really going to impact. When we're in a downward trend, so it's in a good position to be in order to experience that and try to understand how it's going to impact the count, but it might also make it looks better than it is. And I want to highlight the fact that we're not great. We're still, today was 1,000 cases. That's a very, very high number. If we have to go back into a different surge, even if it's milder, it's still a lot of numbers. And it does translate in hospitalization and people in depletion in the work field. Even if people are not going to the hospital, they might feel sick and not go to work. So it has like implication beyond that. And it's really hard to understand them and put them into the model, because as you highlighted, the numbers are what they are. And there is a lot of the numbers that we don't see. We just have the very tip of the iceberg. And I think that tip got even smaller. So we're working, the base is a blurry area. So it's a very good point.
Thank you.
Sure, and then a couple other things from the FD side. Yeah, we did see, as COVID mutated from the original strain to the Alpha variant to Delta to Omicron, the original 3 to 7 day incubation period got shorter. We understood better the viral loads and the period of time someone shed virus versus, if they're vaccinated or unvaccinated. So, as we got more information, that played a role in our assumptions. The one thing couple of things we couldn't really estimate. One, human behavior was never something we could, a factor we couldn't really account for. The other two things were, the secondary tertiary impacts, not just to the hospitals and the healthcare workers there, but essential workers, right? Even though it's less severe than Delta, Omicron is still worse, across the board than the flu. And so you're having huge impacts to essential workers, and that really wasn't captured in the cases, the hospitalizations and deaths. So that's something we're working on now. And then, getting a better understanding of how the impact of Omicron and interplay with hospitalizations and the vaccine status. I know Hilton is doing his best with his team to tease that out for the group. But once again, Hawaii doesn't operate in a vacuum, but we are so unique with regards to our ethnicity makeup, just our demographics, that we can't wholeheartedly just look at how another state's vaccination status is to hospitalizations and just make that assumption because of how unique we are. So just want to put that out for you, but also for the group when you're looking at our work and we're trying to understand the interplays between all these variables. Our population has been unique from the beginning, and which is why, you know, HiPAM stood up, because, you know, we needed a Hawaii specific response. Sorry, go ahead, Monique.
Yeah, if I can just add something, I think you touched, General Ara, a very important point, and that is going to be studied over, it's going to take a few years, I suspect. It's to understand the feedback, the individual feedback to the messaging, right? As we show the numbers, as the media provide the information, the people are reacting and they're changing their behavior. And what is the best way to do the messaging so that the feedback goes with the pandemic and is actually constructive, additional mitigation to the pandemic. So I think there is a lot of question about that people are asking, and that we're going to try to study, like a lot of people are going to try to understand how that worked.
Okay, thank you for the rich discussion, everybody. General Hara, thank you again, sir, for your participation. So one final chat comment: people don't trust the messaging. They are having great results from ivermectin. There is no benefit to reporting illness. So you know, I will say that, you know, there probably hasn't been, you know, once again, when it comes to messaging, a very unified response, even at a federal level, when it comes to understanding the science of, you know, all the different types of treatment. And so, you know, I'm not going to insult everybody's intelligence. There are probably other factors at play when it comes to drug decisions, approvals, et cetera. So once again, thankfully, that's not in my realm, but, you know, we have to be aware of that when we're looking at the holistic perspective. So great point. But, you know, it's been a rich hour of questions and learning from everybody here. I want to thank you all for your time, you know, especially General Hara. Again, thank you for taking an hour out of your schedule. Hopefully we will see you guys next month. We'll have one more, and hopefully by then things will continue to be trending downward in the right direction. Have a great weekend. Have a great rest of your month, everybody. Stay safe and keep in touch. Be well. Aloha.